Hello, this is Dr. Kim Jong-il. Today's topic is treatment of palatal displacement of maxillary lateral incisor. In Part 1, we will discuss in detail about gaining space. There are largely two types of crowding, which are horizontal displacement from the occlusal view and vertical displacement from the frontal or side views. Today, among horizontal displacement, we will discuss the treatment of palatal displacement of maxillary lateral incisor. Palatal displacement of the upper lateral incisor is one of the most common case of malocclusion. When the upper lateral incisor is palatally erupted, the alveolar bone level is reduced, especially at the root apex. Therefore, due to thin alveolar bone, there is a high chance of gingival recession when tipping or pulling force is applied. From occlusal view, anterior crowding can be divided into palatal displacement and mesial rotation of the upper lateral incisor. Crowding is more severe in case of palatal eruption of the lateral incisor than mesial rotation. Palatal displacement indicates palatal eruption of the upper lateral incisor. Let's simply call it PD. Palatal displacement of maxillary lateral incisor can be observed in all of class 1, 2, and 3 malocclusions. In case of class 3 malocclusion, extraction is not recommended even if there is a severe anterior crowding. On the other hand, in case of class 1 and 2 malocclusion, there is a high possibility of premolar extraction. PD of maxillary lateral incisor leads to not only a severe anterior crowding, but also an increased chance of midline deviation to the direction of crowding. Orthodontic treatment can be divided into extraction and non-extraction. For extraction treatment, it should be considered whether to extract the first premolars or the palatally displaced lateral incisors. The biggest problem of extracting the upper lateral incisors is midline deviation. Because of the palatally erupted lateral incisor, the midline is already deviated to the direction of crowding. Of course, the midline can be corrected by extracting the lateral incisor on one side and the first premolar on the other, but it is difficult. In addition, the upper canine has to replace the extracted lateral incisor, and reshaping of the canine may be necessary due to pointed cusp tip. What are the possible problems of the extraction of upper first premolars? Space is created in order to move the palatally displaced lateral incisor into the arch. It is easier to create space in premolar extraction cases than in non-extraction cases. However, there is a limitation to the root movement when palatally displaced lateral incisors move into the arch. Therefore, an additional root labial torque must be applied. In this case, if tooth 14 is extracted and tooth 12 is moved into the correct position, where will the root be located? As the crown moves into the correct position, the root will be further inclined palatally, which is unaesthetic. In some cases, either two of the upper first premolars or the lateral incisors can be extracted. Since tooth 22 in good shape in this patient, it was decided to extract teeth 12 and 24. Let's take a look at the treatment procedure. On the right, tooth 12 is extracted, and rotated tooth 13 should be derotated. On the left, tooth 24 is extracted, and the canine has to be moved posteriorly in order to move tooth 22 into the correct position. Initial arch wire is 004 tier, ni tie with sheath inserted. If sheath is not inserted in the left crowded area, the wire pushes against the lips, causing patient discomfort. Then 016. SS wire with open coil spring is used to move the canine posteriorly. When the space for lateral incisor is created, attach the bracket and move into the original arch form. The rotated canine on the right is derotated by coupled force system. Attach the lingual buttons to the palatal surfaces of teeth 13 and 14 teeth and use power chain to derotate tooth 13. On the left, the first premolar is extracted and the canine is moved posteriorly. Then align the upper lateral incisor, close the extraction space, and finish. Like this case, if there is a severe palatal displacement of the upper lateral incisor, the extraction of tooth 12 can make the treatment easier. There are two processes to consider in the alignment of palatally displaced upper lateral incisor. The first is creating space. Space gaining is needed in all cases, extraction or non-extraction. Because it is difficult to attach the bracket in the correct position on palatally displaced lateral incisor, occlusal force has to be removed first. Then the teeth are re-leveled. After alignment, torque control is required. The basics of MIA orthodontics is strategic leveling and alignment, which is the minimization of labioversion of the incisors in non-extraction cases, and closing of the extraction space without use of TPA or mini-screw in premolar extraction cases. Let's review. First, create space. Second, after space is created, attach brackets. At this time, if it is difficult to attach the bracket in correct position, remove the occlusal force first. Third, slowly jump out the palatally displaced tooth. Fourth, re-level the teeth after the upper lateral incisor is jumped out. Fifth, and finally, perform torque control for root labial movement. First, it is very important to create space. In premolar extraction cases, since the first premolars are usually extracted, canine can be easily moved to the extraction space by using open coil spring in the lateral incisor area. In non-extraction cases, strategic leveling is required to create space. In cases of palatal displacement of the upper lateral incisor, the brackets are first attached to the upper central incisors, canines, second premolars, and second molars. Then, by using open coil spring in the lateral incisor area, the central incisors move anteriorly and the canines move posteriorly. Because the first premolars is not bonded, it can be displaced palatally. The important thing is to open up the space while minimizing the labioversion of the upper incisors. The basics of premolar extraction case is to attach the SWA brackets to the upper four incisors. And at the beginning of the treatment, the bracket is not attached to the crowded lateral incisor. In the maxilla, the brackets are attached up to the first molar at the beginning. After creating space, align the palatally displaced upper lateral incisor. After alignment, use an energy chain between the upper lateral incisors. Then close the extraction space and finish. How about a non-extraction case? In order to minimize the labioversion of the upper incisors, use Kim's brackets, which are SWA brackets with 0-degree torque on the upper four incisors, and open coil spring on Arrow 16 X022 SS wire with crown lingual torque. A shows 0-degree Kim's bracket and B shows SWA bracket. If 0 16 X022 SS wire with -7 degrees crown lingual torque is used, what type of tooth movement occur? The crown is lingually inclined and the root moves labially. Then what kind of tooth movement will occur if open coil spring is used here? In non-extraction treatment, there is a high possibility of crown labioversion, which is unesthetic. When conventional SWA bracket is used, the chance of crown labioversion increases because crown labial torque is already programmed in the appliance. On the other hand, if Kim's bracket and SS wire with crown lingual torque are used with open coil spring, bodily movement of the tooth is possible. At this point, let's think about the force vector. Open coil spring can be used either unilaterally or bilaterally. When it is used unilaterally, lateral movement of the upper incisors is bigger than labial movement. On the other hand, when used bilaterally, labial movement is more likely to occur. This leads to the protrusion of incisors and unesthetic profile, which increases the likelihood of premolars extraction. The same is true of this case. When the teeth are moved, the movement patterns of the left and right sides are different. In this patient, the left side moved faster than the right side, so the left side was aligned first. After the left side was aligned, torque control arch wire was inserted. This torque control arch wire will be discussed in detail in Part 2. While controlling the torque of the aligned tooth 22 with crown lingual torque, open coil spring is used in the tooth 12 area to create space. When the space for tooth 12 is created, a bracket is attached. And NITI arch wire is inserted to align tooth 12 into a correct position. Because there is a possibility of the adjacent teeth to be rotated by the reaction force, either use open coil spring to offset or tie teeth 11 and 12 with figure of 8 tie. After tooth 12 is aligned, proceed to finish. During finishing, in order to control the torque on teeth 12 and 22, add additional L loops between the central incisors and lateral incisors in Mio wire. As you can see from the pre- and post-treatment photos, despite severe anterior crowding, space was created with non-extraction treatment. By strategic leveling, the arch was able to be enlarged. The important thing here is to derotate the upper second molars. If the upper second molars are mesially rotated, it is difficult to enlarge the dental arch. Therefore, arch enlargement is easier if the terminal molars are derotated first. The next topic is what type of bracket should be attached after space is created for the lateral incisor. In case of palatally displaced lateral incisor, it is difficult to attach the bracket in the correct position. It should be considered when and what type of bracket to attach. The options are lingual button, mini-size bracket, or SWA bracket upside down. Typically, the teeth move 1 millimeter per month. When is it good to attach the appliance? It is advisable to attach the appliance when space is beginning to be created. Before space is created, attach the appliance to gradually move the tooth labially. Which appliance should be attached? It can be attached to either the palatal or labial side. The force direction is anterior or labial direction. Let's think about labial and palatal attachment of the appliance separately. The biggest problem with labial attachment is that there is a high possibility of the appliance to detach, so bite has to be raised. In order to raise the bite, blue resin or PBBA posterior bite block with anterior coverage can be used. This may be uncomfortable to the patient, but the bracket can be attached in the correct position. If the appliance is attached to the palatal side, the tooth can be moved more quickly due to greater applied force. But afterwards, the bracket has to be attached on the labial side again. In order to attach an appliance on the palatally displaced upper lateral incisor, occlusal force has to be removed, and blue resin PBB or PBBA can be used. Please refer to the elimination of occlusal force part in the lecture on occlusal plane. Then, where should blue resin be put on? In general, blue resin is put on the first molar or premolar. Blue resin should not be used longer than 1 or 2 months, so other devices should be used if needed for longer period. As can be seen in the picture, the tooth that occludes blue resin is intruded, and adjacent teeth are tilted toward the intruded tooth. Therefore, it is advisable to use blue resin in the maxilla in Class 2 malocclusion, and in the mandible in Class 3 malocclusion. If the bracket can be attached in the correct position, attach the SWA bracket upside down. If it is impossible to attach the bracket in correct position, attach the lingual button or the lingual bracket. And after the displaced tooth is pulled into the arch, attach an SWA bracket upside down. When the brackets are attached, not only the vertical position but also the anteroposterior position should always be considered. Most of the palatally displaced teeth are mesially rotated, so the facial axis has to be located slightly mesially. Both of these must be fulfilled in order to attach the bracket in the correct position. This patient has severe anterior crowding in both the upper and lower arches. In the maxilla, the brackets were attached on the central incisors, canines, second premolars, and first molars. Space was created by the use of open coil spring. A bracket was attached on the palatal side of the lateral incisor, and ERA13 copper knee tie arch wire was used. Teeth 11 and 12 were tied with figure of 8 tie. The palatally displaced tooth moves labially and may occlude with the lower teeth, so raise the bite with blue resin. In February, knee arch wire was used, and a lingual button was attached on the labial side as well for additional traction force. In March, it was jumped out. The palatally displaced tooth began to be moved in January and was moved labially in just 2 months. Then the bracket is attached to the correct position for alignment. It is very important to remove the occlusal force. The tooth can still move without removing the occlusal force, but caution has to be taken because crown of the upper lateral incisor can be even more labially inclined. On the other hand, if PBBA is used in the mandible rotates backward and downwards, so the upper lateral incisor can be jumped out with little movement. Therefore, it is advisable to use an auxiliary device if possible. The appliance mainly used here is PBBA, or posterior bite block with anterior coverage. When is this appliance mostly used? It is used in Class 2 skeletal pattern or Class 3 deep bite. In case of lower anterior crowding, an expansion screw is inserted in the mandible. And then the upper lateral incisor is aligned. At this time, many orthodontists use super-elastic arch wire. When super-elastic arch wire is used, the labial movement of the palatally displaced tooth causes the adjacent teeth to rotate in reaction. In order to prevent this, open coil spring is inserted in the main arch wire, and 90 overlay is used as in Figure C. In this way, the lateral incisor can be aligned while preventing the rotation of adjacent teeth. Today, Part 1 focused on creating space. After creating space and aligning the teeth, whether to remove the occlusal force and which bracket to attach were discussed. In Part 2, we will discuss on teeth alignment and torque control. Thank you for watching.